Hello, everybody. My name is Jens Chapman, and I'm calling in from the beautiful Seattle Science Foundation studios in Seattle, Washington, where I'm sitting with some of my colleagues. Next to me is Dr. Mark Kramer from the University of Wisconsin. And it is a particular pleasure to introduce tonight's live from Toronto special edition of the Global Spine Congress, the Spinal Journal Club, on the topic of spinal cord injuries. One of the, I think it's fair to say, most overlooked public health dilemmas in the world. And it is a great pleasure to have our co-moderators, Professor Michael Fehlings and Professor Jeff Wilson from the Toronto system, kind of chair this AO Spine, initially North American, now AO Spine International effort through the Knowledge Spine Fora, and our Global Spine Journal, representing doctors, co-editors Jeff Wong and Carsten Wiechert, and I are very privileged and proud to have this group help us understand where we are with consensus statements and moreover guidelines statements for spinal cord injury. Where are we and what should we do now? So I am passing the microphone off to my friends and dear colleagues, Drs. Fehlings and Wilson. And please take us through what we're going to experience over the next hour. Thank you all, our international audience, for dialing in, and looking forward to a great interactive hour.
Thank you very much, Jens, and we're very appreciative to the Global Spine Journal and to the Seattle Science Foundation, to the AO, as well as to the Praxis Institute. And tonight's session will be co-moderated by myself. I'm Michael Fehlings from the University of Toronto, and my colleague and dear friend Jefferson Wilson, also from the University of Toronto. I'm going to give a brief background to the topic of this evening, which relates to the new AO Spine Praxis guidelines for the management of acute spinal cord injury, and then Jeff will introduce our three speakers who are fellows in our University of Toronto program. So just to provide context, this is actually the second set of guidelines that AO Spine has put together. And the first set of guidelines were in 2017, published in the Global Spine Journal. We looked at the timing of decompression, the efficacy and safety of methylprednisolone, the efficacy and safety of thromboprophylaxis, the utility of baseline MRI, and the type and timing of rehabilitation. And interestingly, these guidelines and all of the guidelines in spinal cord injury have been subject to quite a rigorous review that was co-sponsored by Praxis and the KITE Institute through a consensus conference. And the instrument that is used to evaluate guidelines is called the Agreed To Instrument, which is the appraisal of guidelines for research and evaluation. And I think just kind of in a nutshell, just to point out that the process that was used to generate these guidelines, which is now reflected in the new guidelines, was felt to be at a high quality standard. And these are actually felt to be the highest quality spinal cord guidelines in the field, according to the evaluations using Agreed To. But guidelines are living documents that require updating. And this is really the genesis of the new set of guidelines, which really are addressing a series of focused topics. The three topics that we'll discuss tonight relate to the role and timing of surgical decompression. And this is an update from the last guideline in 2017 based on a substantial amount of new evidence. The hemodynamic management of acute spinal cord injury last was evaluated the guidelines perspective in 2013 by the AANS and CNS. And there's been a lot of interest in this topic over the last 10 to 12 years. And then a new topic relates to the management of intraoperative spinal cord injury. So the process to generate these guidelines involves what's called the grade process, which essentially involves a rigorous assessment of the scientific evidence. And then there's a guidelines development group with consensus meeting that occurs. So this is the guideline related to timing of surgical decompression 2017, and there's been a substantial amount of new evidence, including this Lancet Neurology article that emerged. These are the guidelines related to hemodynamic management, and this is a landmark contribution by the AANS CNS, and these guidelines relating to the hemodynamic management, as shown in this slide, have really guided management. This is a photograph of Nathan Evenew, who had undertaken quite a rigorous systematic review, and there was quite a rigorous assessment of new evidence related to this. And this, in part, resulted in the desire to review the hemodynamic management. And then finally, we have the whole topic of intraoperative spinal cord injury, related to conditions such as complex deformity, OPLL, severe cord compression, intermedullary tumors, thoracic disc herniations, and so on. And right now, there really is no systematic review and no current guideline. So I just wanted to do a shout out to the leadership team, and in particular my co-chair in this effort, Brian Kwan, as well as Nathan Evenew, Lindsay Tetreault, and then the whole team from Aggregate Analytics, which is an independent statistical group, and then also Alessia Hasenbeller from AO Spine. I should point out that these guidelines were also co-sponsored by the Praxis Institute in Canada. So this is the Guidelines Leadership Committee. We then had a committee assessing the systematic reviews, and then we had a multidisciplinary teams reviewing the evidence and informing the evidence and decision framework on these three topics. And so it's important to recognize that this is a multidisciplinary engagement. It was global in nature. We also had key stakeholder involvement, including people who lived experience, and this was using the rigorous grade methodology and the evidence to decision framework for voting. So again, in grade, you take the quality of the evidence, but in addition to this, you filter this through a multidisciplinary team of clinicians and people who have a key interest in the topic. And then you look at the pros and cons, you look at the resources required, cost benefit issues, health equity issues. Is it acceptable to key stakeholders? Is it feasible? And so on. And so with that background framework, I'll hand over to Jeff Wilson to introduce our speakers.
Thanks very much, Michael. And again, thank you to Jens and everybody at the Seattle Science Foundation, in addition to Global Spine Journal. So at University of Toronto, we're very proud of our training programs, both at the residency and fellowship level. We have 3 adult spine centers in addition to a pediatric center. All of them have their own unique fellowship programs, which is and they're all kind of interlaced underneath the University of Toronto Spine program. Tonight, we have 3 of our STAR trainees who are going to assist us in going over the evidence in this iteration of the guidelines. So Dr. Carlo Pedro is a neurosurgeon and spine research fellow at Toronto Western. He's going to help us to discuss the role and timing of surgical decompression. Dr. Hussein Shakil is a neurosurgery resident currently doing his PhD in clinical epidemiology, and he's going to provide an overview of the guideline for hemodynamic management. And then finally, Mohammed Ali Alvi is a neurosurgeon and a research fellow at Toronto Western Hospital, and he's going to speak about intraoperative spinal cord injury. So with that, I'll turn it over to the first speaker, who will be Dr. Pedro, to speak about the role and timing of surgery.
Yeah, so thank you very much. It's a pleasure to be with you tonight in this journal club. I'm Carlo. I'm one of the spine fellows at Toronto Western Hospital. I have no disclosures for this talk, but again, I want to acknowledge the AO Foundation and Praxis Spinal Cord Institute for the creation of this guideline. So again, as Dr. Fehlings mentioned, in 2017, a clinical practice guideline was issued through the auspices of the AO Spine on timing of surgery. And the guideline back then recommended early surgery with a low quality of evidence and a weak strength of recommendation. And this goes to both the acute spinal cord injury as well as the central cord syndrome population. Since that time, however, several other studies have emerged in the literature, one of which is this individual patient data meta-analysis from the group of Badiwala and colleagues, which looked into over 2,000 SCI patients, overwhelmingly supporting the concept of early surgery less than 24 hours. So one of the main goals of updating this guideline in 2024 is really to upgrade the evidence base for timing of surgery and realizing the emerging literature, especially those that have explored earlier time cutoffs less than 24 hours. So as Dr. Fehlings mentioned, this is a 3-part guideline, and my part will be on the time of surgical decompression. So this was already discussed by Dr. Fehlings. And in this part of the guideline that looked into timing of surgery, there were 21 studies that was used to answer 5 key questions. So the first key question looked into the effectiveness of early surgery versus late surgery, defined as greater than 24 hours. But before we go to the studies, let me share to you one of the dilemmas and issues that was encountered in defining what is important outcome. So the authors in this guideline have used the minimal clinically important difference, but even this concept is highly variable and there's so many definitions in the literature. For this specific guideline, the authors use a 4.5 cutoff for the total motor score based on this literature from the rehabilitation medicine. And as you can see from this slide, early surgery was shown to be associated with attainment of the MCID for total motor score at 12 months, and also using another criteria, which is greater or 2 or greater grades of improvement in AIS grade. Early surgery was associated with a risk ratio of 2.76 at 6 months and a lower risk ratio, but still within the statistically significant range of 1.96 at 12 months. The authors also look at this within the framework of functional outcome or administrative outcomes. Unfortunately, there are no updates on functional outcome, and so the authors just issued the new studies on the administrative outcomes. And using hospital length of stay, early surgery was associated with shorter hospital length of stay compared to late surgery, but no effect on rehab length of stay. Based on patient safety profile, the authors did not see a difference on mortality. So as you can see in this forest plot, based on review of 6 studies, there was no significant difference between early and late surgery in terms of mortality. And in terms of other complications, such as hardware failure, screw pull-out, sepsis, pressure ulcer, and neurological deterioration, a similar conclusion was made whereby there was no significant difference between early and late surgery. The authors, however, issued a caution in these studies because they're very highly heterogeneous with different follow-up duration and also very heterogeneous patient population. So just a caution in the interpretation of this specific part of the guideline. One of the other important key issues that was raised and answered in this guideline is whether this recommendation of early surgery is generalizable in all patient subgroups. We've heard this in many topics or debates on this topic, questioning the validity of this recommendation on different subgroups of patients. And here you can see that in terms of the extent of injury, the authors have shown that there's no interaction term, meaning the extent of injury does not modify the effect of early surgery. And this is the same as true in the level of injury. As you can see, subgrouping patients based on the level of injury, you see that the risk ratio is almost similar to each other with a confidence interval that is overlapping from each other. So the authors have concluded that the level of injury does not appear to change the treatment effect of early surgery. And lastly, in terms of cost effectiveness, well, admittedly, this is one of the most limited number of studies in the literature. The authors only found one good study, and this is published in 2016 using a subgroup of the stasis trial. While there was a tendency for cost saving in early surgery, when the authors did sensitivity analysis, the timing of surgery was not a significant factor. So the authors concluded that neither surgical timing clearly dominated in terms of the cost saving. Lastly, this key question was a update from the 2017, and the authors included earlier time frames. So as you can see from this table in this guideline, the authors explored the studies that look into 8, 4, 12, and 5 hours. However, these studies have very inconsistent and sometimes even conflicting results. As you can see in the 8-hour study, there was a significant advantage of early surgery, but looking at 4 hours or even 5 hours, early surgery actually was more detrimental than late surgery. So again, very heterogeneous and inconsistent results, and therefore the authors at the end was not able to recommend a strong statement about earlier time cutoffs. One of the studies, however, that was not included in this guideline, largely because it was published after the initial analysis has already been done, was the SciPOEM study. This was a UK-based study that looked into less than 12 hours. However, the results were also not significant, although there was a tendency, but it did not reach a statistical significance. And also, there's a large baseline differences and high rates of loss to follow-up. So in the end, we were left with these two very important key messages from this guideline. And here we can see that early surgery is recommended now as an option for adult patients with SCI, but you see that the quality of evidence is now moderate from weak, and from low, and the strength of recommendation is strong from weak from the 2017 guideline. In terms of earlier surgery, as again I mentioned, the authors were not able to recommend strong statement on earlier surgery. More than clarifying some issues, I think this guideline was very important in highlighting some of the knowledge gaps in timing of surgery, particularly in the SCI phenotypes, central cord management, and also the heterogeneous outcome measures in the SCI literature. Of course, the emerging techniques like expansor duroplasty or intraoperative ultrasound are also driving innovation in the field and are likely to also have significant impact in the future. And this is my last slide. I think just one of the strong message from this guideline is that although this is a guideline, it should not be implemented in vacuum. We should always consider some patient-specific factors as well as consideration of resources in the local setting. Thank you very much.
Excellent. Fantastic presentation. Thank you, Carlo. Michael, do we want to spend, there are no comments or questions at the moment in the chat box. Do we want to say a few words about this or discuss, or should we roll in with the next talk, do you think?
Well, I think, you know, Jeff, maybe you might want to comment on the InTwin study that you've launched through the AO, looking at milder subtypes of central cord injury.
Yeah, well, thanks for that plug. You know, I think one of the biggest areas of controversy in terms of the role and timing of surgical decompression for spinal cord injury is the central cord phenotype. And we know that the epidemiology of spinal cord injury is changing. We're seeing older patients without fractures who come in with milder forms of spinal cord injury, usually Asia D or even sensory-only impairments. And so the question is, should we be taking those patients emergently to the operating room? We know that there's historically been a lot of nihilism around treating patients with central cord with early upfront surgery due to previous reports of a lot of risk with such surgery. But we feel that that paradigm is kind of shifting, and that perhaps those are the patients where the greatest benefits actually might be observed. So we've started a prospective observational study within the Spinal Cord Injury Knowledge Forum, specifically looking at this group. So looking at patients with mild spinal cord injury without instability, the so-called central cord phenotype, And it's not a randomized study, but basically we're looking to see how these patients do with early surgical decompression. We're not just looking at Asia grade and Asia motor score. We're looking at things that matter to the central cord population, like hand function, walking, neuropathic pain, spasticity, quality of life. And so we're hoping with this that we might get a better sense of actually how patients do with early surgical decompression, and hopefully allow us some evidence base to make greater recommendations for that group, which we know is an important group.
Thank you. Dr. Robinson, asked a question which commonly arises. Do you take patients in the middle of the night, or can you wait kind of until the next morning? And I think a lot of it depends on the context. So, the type of injury, the age of the patient, the resources and the feasibility kind of doing, surgery and, in your particular unit. So I think that, in a young person, let's say with a bilateral facet dislocation and a severe cervical cord injury, my own view would be that is something that I won't allow to wait until the next morning. On the other hand, there are patients, let's say, that are older, particularly if they have medical comorbidities. It may not be conceivable to operate within 24 hours. So if they're on a factor Xa inhibitor, you may want to have a period of washout and to work them up. So I think a lot of it depends on the assessment of the heterogeneity and the judgment and the circumstances, as well as kind of the personal resources that you have in the
So congratulations, first of all. Thank you for this very nice discussion. Congratulations on taking this topic into greater refinement all the time. Given the heterogeneity of pathologies, now the very helpful differentiation into phenotypes, the multiple variables of age and comorbidity burden, what kind of a patient population will we actually need to try to get really powerful statistical inferences? Jeff, Michael, what's your gestalt on that number?
You want to take that one?
Well, yeah, I mean, I think we have a lot of data now, and I think one of the issues is that this topic has been researched a lot, and I'm not sure that there's a huge interest in doing a huge, broad, sweeping prospective study on this again, because it's a hard thing to study. Any acute spinal cord injury study is very hard to do, at least in a prospective fashion. So I think what we're going to see happen, Jens, is most likely retreat to looking at groups where there's a lot of controversy and that are quite prominent and prevalent, such as the central cord patient population, because I think now the pendulum has shifted so much that, most spine surgeons will take most spinal cord injuries to the operating room quite quickly, usually within the first 24 hours. That's what our survey studies show. But the one holdout is actually central cord, where there's still a lot of uncertainty. So if there's to be further prospective research on this topic, I think it'll probably be limited to subgroups such as central cord, where there's residual mulch gap. But I think what we're seeing, though, is that a lot of spine surgeons have bought into this concept, which wasn't so accepted, as 20, 30 years ago. So it's interesting to see how the pendulum has shifted.
Thank you.
The only other thing I'll add to that is that I think we're also going to see an evolution in data analytics. So, for example, the use of machine learning approaches to try to get a better handle on the heterogeneity of the patients, and to allow perhaps a greater degree of personalization, as well as kind of looking at perhaps better ways to assess outcomes, so that we can then perhaps more accurately define the impact of intervention. So, for example, in the mild central cord syndromes, if I can call them mild, the Asia impairment scale falls down because the patients all tend to do fairly well on that metric, but they may not do as well in other metrics like pain and spasticity and so on. So I think we need better outcomes. Okay, so Jeff, should we move on?
Yeah, sounds great. So with that, I'll introduce Dr. Hussein Shakil, and he will be speaking about hemodynamic management of patients with acute spinal cord injury.
Okay, thanks, Jeff. It's my pleasure to, sorry, just one second here. All right. It's my pleasure to speak here at the Virtual Global Spine Journal Club. And my name is Hussein. As mentioned, I'm a neurosurgery resident here in Toronto, and I'll be presenting the AO and Praxis guidelines on hemodynamic management. So a little bit of like brief background. So there's really only two sort of well-accepted interventions that we can do for acute spinal cord injury, and that's urgent surgical decompression and hemodynamic management. And this is both treatments are largely there to minimize secondary ischemic injury to the vulnerable tissue that's been injured from the traumatic injury. And so in the way of hemodynamic management, as Dr. Fehlings had mentioned, in 2013, the AANS and CNS put out a set of guidelines providing a level 3 recommendation for what practitioners should do for these patients in the way of cardiopulmonary respiratory support. So they recommended first to provide a level of monitoring that was sort of at the ICU or sort of critical care setting, to correct any hypotension, so any systolic blood pressure less than 90 when possible and as soon as possible. And their third recommendation was around maintenance of a mean arterial pressure between 85 to 90 for 7 days following the acute injury. And so the third recommendation was the subject of most of the assessment and review for the 2024 AO Praxis guidelines. And a lot of the rationale was that one, MAP is of great importance and attention, given that it's one of the few non-operative treatments that we have for these patients, but also that there was a lot of literature that came out since the 2013 guideline that was growing in the way of perfusion and the physiology of the spinal cord in the setting of acute injury. And actually, the 2013 guidelines spanned literature spanning up to 2011, and there's been a growing interest in the field of spinal cord perfusion pressure, with ongoing work being done to understand the physiology of the injured spinal cord. And so the guideline committee wanted to address the point of the tight parameters that were given, really a 5 millimeter mercury of 85 to 90 target range, as well as 7-day duration. They wanted to assess the level of evidence around that, because they were also finding that there was really variable implementation in the real world in terms of how these recommendations were being carried out. So as Dr. Fehlings mentioned, there was a multidisciplinary team that was put forward to tackle this problem. And really their team was made up of a combination of surgeons, as well as critical care physicians, first responders, as well as patients with lived experience with spinal cord injury. And they looked at each of the recommendations and voted on whether to endorse or review them. And the first two were kind of well endorsed, while the third, around the target range and duration of MAP augmentation, was the subject of interest for the 2024 guideline. So as mentioned, they went through a rigorous process involving the GRADE framework, where a previous systematic review that was updated by Dr. Evanyu in 2024 was that collated the evidence was reviewed and voted on by each of the members of the guideline group. And just to review the evidence available, there was really only one RCT available at the time of the review, and most of the studies were actually observational in nature. So in terms of the key questions that were looked at in terms of the guideline, the first part was around the actual target range that would be recommended. So they wanted to establish a lower MAP limit as well as an upper MAP limit, and look at the evidence around each of those barriers to the or each of those thresholds for the target range. And then the second part they wanted to look at was the actual duration for which the mean arterial pressure would be augmented. And then the last part of the guideline was looking at the actual choice of agent, and if there was any evidence around benefits or harms around a specific agent that could be put forward. So in terms of the lower limit, there were 14 studies that they identified that were looking at somewhat of a way at this outcome. So the important point that was discussed by the authors was that no study actually directly was a causative analysis of a specific MAP threshold and a worse neurologic recovery below that. And rather, they found that a lot of the evidence was more associative in terms of different MAP targets and neurologic recovery. There were 5 studies that reported some evidence of worse outcomes among patients with a MAP below 70 to 75, but there were additional 5 studies that failed to demonstrate any clear association between these two variables. So based on this, they decide to go with the lower limit of 70 to 75, and they also went to review the remaining evidence around the upper limit. So they identified 3 studies that looked at whether there was any sort of upper limit of no further improvement in terms of MAP augmentation. They did find sort of some evidence that an upper limit of about 90 to 95 millimeters mercury was the threshold beyond which there was no further neurologic improvement. And there was actually some evidence that there could be actually harm to patients if the pressure was being pushed beyond this. And so they looked also at complications associated with different vasoactive agents used to augment the blood pressure. There's a lot of evidence for high rates of arrhythmias and dysrhythmias related to pushing the MAPs for too long of a period. So the recommendation that they put forward is described here. So they suggested a lower limit of 75 to 80, but and an upper limit of no higher than 90 to 95 in order to optimize spinal cord perfusion in the acute setting. And as mentioned, a lot of the quality of evidence was associative, observational nature, so they graded it as very low. And so their strength of recommendation was ultimately weak. In terms of the duration of MAP augmentation, they identified 14 studies that described and reported the actual duration for which the MAP was augmented for measuring their outcomes in this patient population. And 12 studies reported a MAP of 3 to 7 days, and 2 studies, one of which looked mainly at intraoperative MAP augmentation, the other one within the early period. So interestingly, the guideline development group found that there was a lot of variability in terms of the voting for the different for the different duration amounts. So about 50% voted for 5 days, 30% for 3 days, and then the remaining for some range between that. So they ultimately proposed to recommend a range of days to provide more autonomy to the practitioners who are treating these patients and allow for more of a personalized approach based on injury severity and patient factors. So the actual recommendation put forward is shown here. So they suggested that the augmentation of mean arterial pressure be for a duration of 3 to 7 days in order to optimize perfusion for the acute traumatic spinal cord. And again, the quality of evidence was very low, with the recommendation being weak. So the last part of their guidelines was trying to look at if there were any specific agents that they could identify that would be sort of beneficial to the injured cord. And they found 3 studies that looked at specific agents, mostly around dopamine and phenylephrine. They did find evidence of complications, which were reported in their guideline, but importantly, none of the studies actually addressed if there was a specific agent that was better at promoting blood flow and oxygenation to the injured cord. And given the very limited evidence, they decided to put more forward a statement that the decision for the actual agent should be left to the attending physician. So a lot more autonomy, again, given to the practitioners and the critical care physicians taking care of these patients in the real world. So the next steps, as Dr. Fehlings mentioned, the guidelines are a living document, and the leadership team will review them in 3 to 5 years. And if, of course, if there's any emerging evidence about new benefits or harms or new available treatments, knowledge, or outcomes that are critical, then they'll be revisited sooner. The one point that was mentioned within the guidelines that I did want to address is about the emerging interest in spinal cord perfusion pressure. And there's a lot of work done by Papadopoulos and colleagues, as well as Brian Kwan and colleagues, around measuring spinal cord perfusion pressure, which is felt to actually be a more relevant metric than MAP itself. But the committee felt that there was a lot of variability in terms of the centers offering this kind of care, and so they felt that it was not something to be addressed at this point, but maybe something for the future as further kind of prospective results come out. The most prominent of which was mentioned was a Casper trial, which is ongoing and likely to provide more insight. So key changes for the guidelines was, again, as mentioned, the widening of the actual MAP parameters, so lower limit of 70 to 75, an upper limit of 90 to 95, as well as widening of the recommended window of duration for treatment to allow more sort of flexibility and autonomy in terms of the practitioners taking care of these patients to personalize some of the treatment choices around the specific patient as well as the specific injury that was presenting. And as sort of discussed, a lot of the strengths of the guideline is around the rigorous methodology in place that allowed for transparent and objective reporting of consensus decisions from their multidisciplinary team. And the limitations were largely from the available evidence that was reviewed and some of the evidence from indirectness from the studies addressing other questions, but sort of drawing emerging conclusions based on what was available. So I'd like to thank the AO and Praxis as well as Seattle Science Foundation for the opportunity to speak here today, and I'm looking forward to the discussion.
Great talk, Hussein. I think one thing about guidelines is they're quite good at illuminating and showcasing what we know, but they're also quite good at showcasing what we don't know. And I think that rings true for the hemodynamics. And a lot of the evidence that's within those guidelines actually comes from decades ago. And even really before surgical decompression in an early sense was mainstream. So I think that's one area that we certainly need more evidence for. I guess the question maybe, Dr. Fehlings, what's your practice now for, say you have a patient come in with a cervical fracture dislocation, incomplete injury, you fix them quickly, they go to the ICU. What do you do now in terms of how long you maintain MAP parameters, what you target, and for how long?
Yeah, thanks, Jeff. So I think that we're still using MAP parameters. We don't really, I think, have a standard around spinal cord perfusion pressure, so we're not routinely putting in lumbar subarachnoid catheters. I think in a person with a severe cervical cord injury, like an Asia A cervical cord injury, we would, I think, go the week and augment the pressures, and we would be in the range of 80 to 85. But in, say, an older individual, particularly with an incomplete cervical injury, there is less issues with neurogenic hypotension, and then the complications and issues with, say, vasopressor support have to be weighed against, the potential benefits. So I think there we would be more cautious, I think, around the use of inotropes, as long as patients were maintaining their pressures, and certainly we wouldn't necessarily have such a patient in the ICU for like a full week. And so I think like the current guidelines largely reflect the 2013 AANS-CNS guidelines. We couldn't really strengthen them, except I think it provides a kind of a broader range of the MAP just to make it more practical, but also allows the clinician to have a bit more judgment in terms of the length of time. So it's not kind of rigid around 7 days. And we were finding that people weren't really necessarily compliant anyways with keeping everybody in the ICU for 7 days. So I think it's largely reflecting practice. Jeff, you've been participating in the Camper study. What's been your own personal experience with lumbar drains and the data that emerged from the use of lumbar drains? Is it something you think that is you would see using outside the context of the study, or do you think it needs more data?
Yeah, I think certainly it needs more data. I mean, I guess the real expert on this is Brian Kwan, who's been leading these studies. The first iteration of his study was called the Camper trial, which was performed, I guess, over a decade ago now. And basically, it wasn't an interventional trial, but basically they placed lumbar drains on all patients with spinal cord injury and tried to adapt this principle from traumatic brain injury, which instead of looking at maps to gauge the extent to which we're perfusing the spinal cord, we're actually looking at spinal cord perfusion pressure, which is looking at intrathecal pressure, or map minus intrathecal pressure to look at spinal cord perfusion pressure, and it's similar concept to TBI where we look at cerebral perfusion pressure. The challenge is that it's actually it's quite difficult to quantify intrathecal pressure and to drain CSF for a number of these patients, because as we all know, lumbar drains can be a bit finicky. They can be a bit temperamental. The waveform is not always so reliable, and sometimes they don't drain properly. And we often see difficulties with them not draining properly if the extent of spinal cord decompression is not adequate. So if the subarachnoid space has not been opened during the index procedure. So yeah, look, I think that's the future, and I think that is where we want to go. But there are still some very practical challenges that need to arise before we get, or to be, overcome before we get there. The one take home that came from Brian Kwan's paper, the initial Camper study, was that to try to avoid spinal cord perfusion pressure less than 65. That was those patients that had spinal cord perfusion pressures less than 65 did worse from a neurological outcomes perspective. So if you are choosing to monitor intrathecal pressure and measuring spinal cord perfusion pressure, that's one metric to try to use to help improve outcomes. But still a work in progress, but hopefully where we're going in the future.
Very good. So maybe we should move to the third talk for time.
Sounds good. So the last talk tonight will be given by Dr. Mohammed Alvi. He'll be speaking about intraoperative spinal cord injury and the new guidelines surrounding that.
Perfect. Thank you, Dr. Wilson. My name is Mohammed Ali Alvi. I'm a research fellow at Dr. Fehlings lab, and as well as a second-year PhD student. And I'm going to be talking about a third part, which is looking at intra-op spinal cord injury. So as you all know, intra-op spinal cord injury is an inherent risk to any spine surgery, and it's consequential not just for the patients, but may have some legal implication for the surgeon and care team as well. The estimated incidence of intra-op SCI is between 12 and 57 cases per million, and varies depending on the pathology, the region of surgery, and the surgical approach. The reason we actually studied intra-op spinal cord injury as part of this focus issue was there's been growing consensus now that SCI has to be grouped into traumatic and non-traumatic, and intra-op SCI is actually a unique element within the non-traumatic group. So we wanted to destigmatize what is actually known about this relatively rare event and understand the several aspects of it and present some management approaches. So my colleagues in Dr. Fehlings have already gone over the GREEN methodology, so I'm just going to skip ahead. So the first part of this was looking at defining intra-op spinal cord injury and looking at the risk factors. So the guidelines development group actually performed a scoping review of previous definitions for intra-op SCI, and then based on a Delphi process, put forth this definition, which was a new or worsening neurological deficit attributable to spinal cord dysfunction during spine surgery that is diagnosed intraoperatively via neurophysiological monitoring and a wake-up test, or immediately post-operatively based on clinical assessment. Next, we looked at risk factors for development of intra-op SCI. So again, we performed a scoping review, and then based on a Delphi process, came up with this list of 7 risk factors that may predispose patients for an intraop SCI. And this list includes high-risk deformity, rigid thoracic curve with high deformity angular ratio, revision congenital deformity with significant cord compression myelopathy, extrinsic lesion with cord compression myelopathy, intramed tumor, unstable fractures, extension distraction injury, and OPLL with severe cord compression, moderate to severe myelopathy. Next, we wanted to study the role of neuromonitoring for diagnosing intraop spinal cord injury compared with immediate postoperative clinical assessment. Intraop monitoring, as you all know, is employed to prevent neurological deficits and identify intraop maneuvers that can lead to neurologic injury. It may consist of sensory monitoring with somatosensory evoked potentials, motor evoked potentials, and monitoring with EMG. While there have been previous systematic reviews and meta-analysis, they were siloed and focused on a particular surgery or particular pathology. So we wanted to perform a comprehensive, all-encompassing meta-analysis of all spine surgery. So this was actually a diagnostic test accuracy meta-analysis, which is different from a traditional meta-analysis. In a traditional meta-analysis, you're looking at computing relative risk or odds ratio for comparing one treatment to another. Here, we are actually computing the diagnostic parameters of a modality and comparing that to gold standard. So you're actually looking at true positive, false negative, and true negatives. And then these are pulled together to come up with these parameters, which are sensitivity, specificity, diagnostic odds ratio, and they're presented using forest plots and summary receivable operating characteristic curves. So we identified a total of 164 studies after applying our inclusion and exclusion criteria. So for somatosensory evoked potential, based on 52 studies, we found a pool sensitivity of 67.5% and a specificity of 96.8%. For MEP, based on 75 studies, we found a sensitivity of 90% and a specificity of 95.6%. For EMG, based on 16 studies, we found a sensitivity of 48.3% and a specificity of 92.9%. And finally, for multimodal neuromonitoring employing a combination of these modalities, we found a sensitivity of 91% and a specificity of 93.8% based on 69 studies. So then using the gray criteria for looking at the risk of bias, the quality of evidence for all these modalities were found to be low. We concluded from this meta-analysis that intraop monitoring, in particular the use of multimodality techniques, may provide an accurate assessment of the physiologic integrity of spinal cord tracts during surgical interventions, and that these data support the argument that IONM should be used in surgical management of patients who are deemed to be at higher risk. So as Dr. Fehlings alluded to in the earlier slides, after performing knowledge synthesis, GRADE basically includes using an evidence to decision framework to inform guidelines, which includes these questions. And based on these questions and working with the guidelines development group, we came up with a strong recommendation that basically said we recommend that intraop physiological monitoring be employed for high-risk patients. So some of you may ask, how come in the presence of low quality of evidence, we can come up with a strong recommendation? And I think that's the beauty of GRADE that Dr. Fehlings alluded to earlier. GRADE provides separate frameworks to judge the quality of evidence and strength of recommendation. So in addition to quality of evidence, the GRADE also recommends looking at consideration for perceived benefits, harms, patient values, feasibility, and implications of equity. And the guidelines development group was composed of not just spine surgeons, but patients with lived experiences and other folks. So based on all of that, since other factors were accepted by the guidelines development group to strongly weigh in favor of making the recommendation, this helped mitigate the impact of low quality of the evidence. Next, we actually wanted to look at the management of intraspinal cord injury. So for this, we performed a scoping review, and we divided it into 2 parts. First part looking at intraop considerations in the event of an ISCI, and the second part looked at what measures may be undertaken. So in terms of intraop considerations, we divided into 3 parts: anesthesiologic considerations, such as ruling out hypothermia, MAP correlates, ruling out hypercapnia; technical considerations, such as electrode setup or confirming proper patient positioning; and surgical considerations, such as looking at compressive force of the neural element or checking for cord distraction during deformity correction. The next part, we looked at measures that should be taken in the event of an intraop SCI. And again, we divided this into 3 parts. This was actually adapted, modified from a previous checklist that was provided by Vitali et al. In 2014. And again, those 3 parts are surgical, neurophysiological, and technical measures. So taking all of this together in the 4th part of this of the intraspinal cord injury, we came up with this care pathway, which is a 5-step care pathway looking at first initial clinical assessment, that is making the determination if a patient has high risk characteristics, which are part of those 7 characteristics that I showed in the earlier table. Then looking at preoperative planning, surgical and aesthetic planning, the step and intra-op management, which is a checklist by modified from Vitali et al., and then post-op management. This is the first evidence-based comprehensive guideline care pathway for prevention, diagnosis, and management of intraop SCI using GRADE methodology. We believe that this work will facilitate a reduction in the incidence of intraop SCI, and we welcome actually prospective studies implementing this care pathway and see if it can lead to a reduction of incidence of intraop SCI. Based on this care pathway, we made a second recommendation. This was a suggestion, a weaker recommendation, which said that we suggest that patients at high risk for intraspinal cord injury during spine surgery be proactively identified. That after identification of such patients, multidisciplinary team discussions be undertaken to manage patients, and that an intraoperative protocol, including the use of neuromonitoring, be implemented. So the takeaway is that although uncommon, intraop spinal cord injury does represent an inherent risk with any spine surgery, we were able to present a unified definition of intraop SCI and also delineated risk factors for intraop SCI. We next performed a diagnostic accuracy meta-analysis of neuromonitoring and then proposed a 5-step treatment algorithm for management of potential ICI. As suggested earlier, I think implementing such a care pathway will lead to prospective studies, which will further help us reduce the incidence of intraspinal cord injury. Thank you very much.
Great presentation. Yeah, excellent. So I think really to be congratulated for addressing this topic, which we all know about, think about, and probably have experienced, but none of us probably have seen an evidence-based framework for dealing with it before. So I applaud you for that. One question I have is, you talked about and presented the guideline on these high-risk cases that for which we should probably be using intraoperative neuromonitoring. But it came to my thought that, of those cases, many of them represent urgent emergent pathology that often may come up after hours, say, unsocial hours after 5 p.m. on weeknights or on the weekends. And I can speak personally that at my institution, we have great neuromonitoring during social hours, but not such great access to it during unsocial hours. So is that guideline putting me in a little bit of hot water if I don't use neuromonitoring for those pathologies at unsocial hours? And is this something I should be taking to the hospital administrator and say, look, get your act together because this is the standard?
Yeah, I think maybe I'll speak to that. So that kind of gets to the kind of the heart of the matter. I think that in the evidence to decision framework, it was recognized that the implementation could present challenges in terms of the lack of availability of intraoperative neuromonitoring in centers, or when it is available in centers, they may not be available after hours or on weekends, which represents a challenge. And so I think in that context, the guidelines kind of represent a suggestion, but it's recognized that there are feasibility issues. And then the other thing I think that kind of emerged, which will require validation, our suggestion was that people consider either developing their own care pathway or perhaps using the one that we had proposed, so that, you know, you could actually then see whether the rates of intraoperative spinal cord injury perhaps might be bumped down, you know, and kind of looking kind of in a prospective fashion, kind of what the results might be in terms of implementing, you know, these care pathways. Because right now, you know, there just aren't prospective studies evaluating that, you know, the implementation of such a care pathway influences outcome. My sense is that it probably does. It makes sense that if you have a care pathway and you have an algorithm that people follow it, you know, in other areas, it tends to improve care, but it needs to be proven. So I would say right now, you know, overall, the level of evidence for this particular set of recommendations is at a weaker state. And so I think this is really kind of a first effort, but there's a lot of further work that will need to be done to, you know, to raise the level of evidence and to address these. And then finally, just around the feasibility of all of this, you know, we're also at Toronto Western faced where, you know, we don't have neuromonitoring in the middle of the night. We have it on weekends, but we're fortunate, but, you know, like not kind of in the middle of the night as well. And there are sometimes you have to take patients on an emergent basis. So we're faced with that as well. You know, I think the logistics and the feasibility are issues. Just check the chat, and
I think Jens is trying to speak, but we can't hear him.
So congratulations, I want to second that, to this great and overlooked topic. And as Dr. Fehlings and Dr. Wilson have reported previously with the NeuroRisk study, much underreported and underappreciated problem. So thank you for highlighting this. And this is a very sophisticated and pragmatically plausible thing. For me, the problem that is not reflected in the literature is the high utilization centers usually have a very high degree of specificity, much higher than the low users. So this is a really big deal for us. So the more we use it, the better we get. There's a tremendous pressure in the US. I know that from multiple centers where administrators are trying to cut costs, and this is one of them that's on the chopping block. So just wanted to identify this dichotomy of countercurrent problems. And the sophistication of electrophysiologists clearly rises with higher utilization. It's actually astonishing. One thing that I missed is contraindications to MEPs. So as we're doing this more and more, and as patients get sicker, there are a number of factors where there are actually very significant contraindications or concerns to MEP use. Seizure disorder, certain monitoring or stimulator devices, certain spinal conditions may also be a contraindication, such as the ankylosing spondylitis fracture. So thoughts on contraindications of MEPs nowadays?
Yeah, so I mean, you've raised kind of a lot of points, and there was also a question for Randy Davis in kind of in the chat, but I think the issue kind of the cost benefit is there, and certainly kind of in lower risk cases, say a routine anterior cervical discectomy infusion, a routine lumbar decompression, I think it's very acceptable not to use evoked potentials. It's great if you have it available, but I would not fault anyone for not using, you know, these kinds of techniques. And there is evidence to indicate that the use of these approaches doesn't necessarily improve, you know, outcomes. There was a nice study by Jiten Badiwal, actually out of Toronto, looking at data there. You know, contraindications to MEPs, I think you kind of indicated what some of those, you know, might be. In general, I think it's quite safe to use. You know, Jeff, are there any situations in your own practice where you'd be hesitant to use MEPs?
The biggest one is patients with epilepsy or seizure disorder. That comes up a lot. We've been able to use it in patients with pacemakers or spinal cord stimulators often if they turn them off. But everybody's level of comfort is different also. It depends on the neurophysiologist of the day also. So, but yeah, there are certainly times when they say we can't use it.
Yeah, you know, the use of monitoring is a team sport, and it's like doing surgery. You know, to be good at it, you have to do a certain volume of this. You need to work together. So if you just do it once in a while, you know, it doesn't flow as well. So there is that element of that I think that's been our own experience as well, that you do have to use it a fair bit to get good at it, because otherwise you start running into issues where you have a lot of false positives, and you know, it becomes quite annoying. I just wanted to make a comment on Randy Davis. Thank you for the compliment, Randy. You're hilarious. And yeah, I mean, I think you raised the point as an experienced clinician that, you know, it is very important if a patient does decline neurologically, and it happens to all of us, that you know, prompt attention to this, getting imaging to assess the placement of implants and to figure out what's going on is important from a medical perspective in terms of the management perspective. And as you've indicated, you know, there may be medical legal implications there as well. So I think your point is well taken in the commentary. Professor Chapman, thank you for the opportunity to do this. Did you want to wrap things up?
Yes. So first of all, congratulations on this body of work. I think I speak for everybody. We have gained tremendously from your work at the University of Toronto and your hospitals, your clinical experience, your basic sciences lab. You've really pushed the whole agenda way forward, and you've consolidated our knowledge base with these very helpful guidelines and updates. Thank you for taking the late time to kind of present this, put this together. And on behalf of the Global Spine Journal, we thank you for your ongoing tremendous contributions that we're very proud to present and also publicize around the world with a different formats. So we're very grateful to you in many regards as individual practitioners, as well as on the global knowledge front. And we've had a nice audience from around the world, and we'll look forward to further interactions as this will be broadcast out through our various outlets. Thank you very much.
Thanks, everybody.
Thank you, everyone. Appreciate the opportunity. Have a good evening.
Care.
Thank you.
Thank you.